the director of the Hearing Loss Association of America in Indianapolis chapter. We are an affiliate of the National, which the National, many of you know, is located in Maryland. Today we have Dr. Cathryn Luckoski. She is an audiologist in the Indianapolis area. I would like to introduce you to her. She is going to be speaking about cochlear implants, the who, what, when, where, how. You'll get to learn everything that you've probably never heard about cochlear implants because she will give you an in-depth information, okay? So I will begin with the introduction. And after I am through, I will turn it over to Dr. Luckoski to begin. For over 25 years, Kathy has provided patient-directed care in the management of hearing loss. A hearing disorder impacts development, aging, communication, and the individual's ability to manage daily life. Kathy has the goal to help the child, family, and adult understand their disorder and manage their treatment to achieve life at the fullest. Her specialties include implantable technologies for severe hearing loss, amplification and assessment techniques to diagnose and prove successful outcomes with treatment. After working at centers in California and Indiana, Kathy was happy to found a home with Ascension St. Vincent in 2014. The mission of Ascension aligns with her values to welcome individuals seeking exceptional care with an open heart. She graduated from California State University, Northridge in 1993 with a Master's of Science degree in Audiology and returned to school at Indiana University to complete a Master's of Business Administration degree in 2014. Her husband and she moved to Indiana in 2000 with their young family. Since the kids have grown, she enjoys traveling and long walks with her golden retriever and lab. Oh, awesome. Juniper and Daisy. By the way, I'm a huge Labrador retriever lover, and I have one. I have a puppy. So with that, I will go ahead and turn it over to Dr. Luckoski, and everyone should be muted. Thank you so much.
Thank you, Teresa. That was a lovely introduction. I'm going to share my screen. Excellent. So you all should be able to see my screen now. Please let me know if that is not the case. So yes, I am going to talk about cochlear implants and from the patient perspective, because these are, that's where you guys would be for the most part if you're thinking about getting a cochlear implant. So we are going to talk about who, what, when, where, and how to be successful with a cochlear implant. But this is just a single presentation. So keep in mind, there are many more resources that you can access. And I would encourage you from the resources that I give you in the presentation to seek those out. We're going to start with a story, actually two stories. And you already heard that I have a favorite friend in my golden retriever, Juniper, and a second one in my lab, Daisy. So we're going to use Junie and Daisy as our lead stories. Daisy, if you can imagine, has a cochlear implant. She is in her mid-60s. She's retired. She enjoys going to lunch with her friends. She enjoys golf, and she enjoys visiting the lake house with her grandchildren and her family. In her mid-40s approximately, she started to have a hearing problem. She did not like the idea of hearing aids. She did not like the idea of having a hearing loss. So she waited. She waited until she was in her 50s before she found the smallest set of hearing aids that she could find. Unfortunately, after she retired, she found it more and more difficult to enjoy lunch with her friends, to hear her grandchildren when she visited the lake house, and she started canceling her golf dates. So she thought there must be something else. She didn't like the idea of getting another hearing aid. Those other hearing aids were too big, too clunky. She wanted something that would help her hear better and be easier to use. She thought about a cochlear implant, backed off of that after a little bit of consideration. But then one day she had lunch with someone that had a cochlear implant, and this person said it was wonderful, it was life-changing. And so she met with an ENT, she scheduled a surgery, she got an implant in one ear. On day one of turning on the implant, she was so disappointed. What she heard was something that sounded tinny, it echoed, speech was not any clearer. Why did she go through this process? Why did she get this? She regretted it immediately. She was encouraged by the audiologist. She was reminded about the expectations around an implant and the idea that it takes time. We have to give the ear time to heal, to recover, to rehab, to learn. She stuck with it. She wore the implant. She kept returning for all of her visits, always does. About a month into having her implant, she met all of the test measures that the audiologist puts out to prove that it was a success. Her audiogram looked good. Her speech clarity scores were good. She hated the implant. She regretted the implant. 2-3 years later, she is back to having lunch with her friends. She's back to visiting the grandchildren in the lake house. She's scheduling golf dates. She has never not said that she regretted getting the implant. So that's Daisy. Junie, though, Junie loves her implant. Junie is in her mid-40s. She has had a hearing loss for most of her life. She started to wear hearing aids as a child. She's always worn hearing aids or some hearing device. She's always been somewhat reluctant to change anything in her hearing technology. Successfully graduated high school, graduated college, started a business, started a family. But she started to also have these symptoms. She was exhausted at night. It was so much work to hear and listen throughout the day. She was missing information in business meetings. She was missing stories from her children in the car. After some consideration and a lot of research, she decided to have an implant in one ear. So she had surgery on day one when the implant was turned on, a month after surgery. She was very disappointed. The sound was tinny, it echoed, it wasn't clear. But she remembered from all the research that she had done that you have to stick with it. Almost from day one, Junie took off her hearing aid from the opposite ear. She spent 30 to 60 minutes a day listening with just the implant. She listened to hard things like music. She listened in restaurants. She listened to her children. And within a month of having turned on the implant, she not only met all of the audiologist targets, but she was very happy with the implant. She saw it as a positive in her life. In fact, such a positive that 10 years later, when the same symptoms started to reoccur because the hearing aid side had progressed, noticing that she was tired again in the evening, she was missing things in business meetings, not hearing her children as well, she got a second implant. And she remembered the day that the second implant turned on, that the sound wasn't going to be sound. It was going to be something very, very different. The ear was still healing. She had the advantage of her first implant. So from day one, she took the first implant off 30 to 60 minutes a day. She practiced, she listened to the hard things. 1 month into using her second implant, she met all of the audiologist targets. And she said, it's incredible. It's like I went from having a box of 16 Crayola crowns to having a box of 64. There's just that much more color in my life. So we're going to talk about Junie and Daisy through this presentation and kind of tease out, well, what is it that's so different between Junie and Daisy? And what you might think is the main reason for the differences well, you might be surprised. There actually are a lot of things in those stories that highlight the control that someone has when they get an implant and how they can make something kind of amazing happen from the experience. So as Teresa said in my introduction, I do work at Ascension St. Vincent. Just a real quick note on the side, we have two offices. One is in Fishers and one is in Carmel. I enjoy working with my patients for hearing aids, for testing. I see children, I see adults, and then I see a lot of implant users. I also like to travel. So these pictures are from a recent trip that we took to celebrate my son's graduation from IU recently. And that's a beautiful volcano in Costa Rica. It's Arenal volcano. Okay. So coming back to who can qualify for a cochlear implant. And I can tell you that in my practice, there are a lot of different questions I get about cochlear implants. The highlighted questions on this screen are the ones that I get the most often. You know, should I consider a cochlear implant? Who should get a cochlear implant? What's the best technology? That has to be the top question that I get. And how do I manage my life with a cochlear implant? I can barely manage my computer or my phone. There are also these sub-questions about where do I start? Should I get one now? Should I wait? And we're going to kind of cover a lot of these questions, focusing on those three main questions about who should think about an implant, what the best technology is, and how to manage your life with an implant. So starting with candidacy. There are a lot of people that do not pursue getting any type of hearing technology when they have a hearing loss. Over 28 million adults could benefit from hearing devices in the United States, and most choose not to pursue hearing devices. The interesting thing about that is we can't consider a cochlear implant for anyone until they've tried a hearing aid. And tried isn't just an over-the-counter hearing aid. Those aren't sufficient. It has to be a hearing aid that is fitted and prescribed by an audiologist. In other words, a well-fitted device. And then you have to have used it for at least 3 months, maybe longer, and then we can actually see if it's helping you. So then once you have that evaluation, once you have a hearing aid, we can consider evaluating you for a cochlear implant. As of July of 2022, more than 1 million cochlear implants had been implanted worldwide. This is a technology that's been available for over 30 years around the world. In the United States, just under 120,000 adults use implants, and that was as of a couple years ago, and approximately 70,000 children use implants. However, for every 100,000 people with a hearing loss that could qualify for an implant, a very, very small number actually get one. 244 out of 100,000, 7, 8, 9 years ago, 350 out of 100,000 about 5 years ago. And as the population ages, where we're going to have hearing issues become a greater and greater challenge, it's actually fewer within that population that will choose to get an implant. So why is that? Why is there a reluctance to pursue effective treatment for hearing loss? Cost is probably the biggest first barrier to getting any type of hearing treatment. And that's singular, it's a singular barrier for hearing aids because hearing aids are not covered typically by most insurance providers. And they're expensive. I know they're expensive. I'm not going to tell someone that they aren't. It's anywhere from a couple $1,000s to $6,000, $7,000 for a good set of hearing aids. That's why over-the-counter hearing aids have become so much more popular. However, once you have a hearing aid and you have used your hearing aid for the prescribed amount of time, then cost for an implant becomes less of an issue. Implants are not the same type of device. A hearing aid is considered durable medical equipment, but a cochlear implant is a prosthetic device. It's a completely different class of medical device. Insurances, both private and public, often cover the cost of a cochlear implant. So if we've gotten past the hearing aid barrier, we can move forward through that very minimal barrier of cost. The second big one, and I highlighted it, is access to services. In the past, and I've done this for about 30 years, a cochlear implant was accessed through a specialty center and a specially trained set of people, speech pathologist, audiologist, ENT. However, in the last probably 10 years, but more 5 years, the implant companies have made it a goal to train more and more audiologists so that you don't have to go to a specialty center in order to access the service. You can go to maybe your local audiologist, and they should have sufficient training to give information, maybe even complete a preliminary evaluation, and then provide a referral on to the next step for consideration to get a cochlear implant. So we're slowly breaking down that barrier to care. The next set of barriers: trust in the device, understanding what an implant is, information about an implant. Those are things that are also slowly kind of dissolving because our community around hearing loss and cochlear implants is expanding. The other thing is that when you get a hearing aid, from the time that you see the audiologist to when you get the device is about 3 weeks. But when you're thinking about an implant, it could be up to 6 months. That's a long time to do a lot of research on your own and to meet people that have a cochlear implant. It's also a great period of time to develop your support network in case you decide to go ahead with an implant, whether it's now or later. That support network will be there for you to kind of work you through those more difficult times. The aesthetics of a cochlear implant, that's always been like top of mind for most of the patients that I see. Implant equipment, the external pieces that you wear, are bigger than a hearing aid. And it's different. And if you have had kind of this sense that you really don't want people to know that you have a hearing loss, the aesthetics of an implant really just stands out there to highlight, hey, I have a hearing loss and now I'm wearing this thing to help me hear. And you get a lot of questions about it. But over time, the aesthetics have certainly improved. In 30 years, I've seen the sound processors go from something that was handheld, clipped to a belt, to something that is literally now behind the ear without anything on the ear at all. And then there's always the question, well, is it really going to help me? And the answer is, if you've tried a hearing aid and you've put your time into figuring out what you need to hear and how a hearing aid helps you or doesn't help you, then you can set appropriate expectations, and the benefit will be there. The benefit is neurologic on one side that we can prove through our testing and through conversations with our patients. And then it is there as well in different parts of your life. It's not a perfect fix. It's not that you hear everything absolutely perfectly or normally compared to what you might have had, years ago, but it expands on your ability to continue connecting with people and hearing people and communicating, and the benefit definitely is there. Starting is something that we're going to talk about a little bit later in the presentation, but now with research and the expansion of information into the professional offices that manage hearing loss, you can actually start in many, many different places now compared to 10, 15 years ago. If you don't do anything for your hearing, there is a significant and real effect on cognitive processing over time. In the short term, hearing loss that's untreated creates this sense of, you're losing connections, isolation, fatigue from not being able to hear what you need to hear through the day and having to concentrate so hard that long-term memory is affected, executive function is affected. In fact, through research, we've learned that untreated or insufficiently treated hearing loss is estimated to account for up to 8% of dementia cases, diagnosed dementia cases. This means that hearing loss might be responsible for 800,000 of the nearly 10 million new cases of dementia that are diagnosed every year. everything that we can do to help our bodies and help our minds as time moves forward is a benefit. And whether it's with a well-fitted set of hearing aids or a well-fitted implant, being able to hear and connect with the people around you is critical to maintaining your ability to manage your daily life and independently make decisions for yourself, just to be part of the world, to make a connection. So what I hear often in my office is, when I'm testing, it's not the real world. You know, I run a series of tests, and they're benchmark tests, they're baseline tests, so that we have a comparison that we can make from one point in time to the next once we've offered treatment, or to track changes in hearing. What we know is that's not the real world. I've never, ever thought it was the real world, that quiet little sound booth that I'll make people go into so I can test. I also know it's not very much fun. What I need, though, is that information so that I can best help you. And we do have, hopefully, the ability to do that testing and then provide an element of counseling and direction for you. So that's why we do all of that testing. That's why we make you sit through it. It's really not to cause more anxiety in your life. It's to find out what you hear on an audiogram. But there are two important pieces to hearing. One is, and there probably are many, many more, but two of them that help us to determine what to do best for you. One is, how loud do we have to make sound for you to hear it? And the other is, once you hear it, is it a clear sound? What you need to hear and hear well is what's on this graph at the very top. That's the normal box of hearing. And the way to look at this is, if you look toward the left of the screen, there's a number at the top that's 125. That's in hertz. It's a very, very low tone. And as you go across the top of the screen, all the way to the right, you see the number 8,000. That's a very, very high tone. It's a high pitch. Those are the frequencies, the tones that we're testing, and they are the broad range of sound that's important for hearing, communication, learning, for daily life. As we go down the left-hand side of the graph, those are loudness levels. 0, 10, 20, those are all within the normal range. And then we get to 30, 40, that's in the range of a mild hearing loss. 50, 60, coming up to 70, that's more moderate, close to severe. Once we get below 90, 100, 110, 120, we're in a profound level of hearing loss. And these pictures on the graph are giving you a representation of approximately where some of the sounds in our everyday life fall, including speech. So what does an audiogram look like for someone that might be a candidate for a cochlear implant? Well, rather than hearing at the top of that graph, the hearing levels fall into the bottom of the graph. It's more severe to moderate. The candidacy criteria are medically set by the FDA, the Federal Drug Administration. I always say FDA. Anyway, a candidate basically is someone that hears at the bottom of that graph. For an adult, it's someone that's over the age of 18. They have normal structures beyond the inner parts of the ear, meaning the hearing nerve is intact, and that nerve is connecting to the brainstem, and the brainstem is intact so that sound can travel or information can travel to the hearing centers in the brain. They have to have tried a well-fitted hearing aid for 3 to 6 months. And then we have to be able to prove that there is little to no sufficient benefit from that hearing aid. And that means, in terms of clarity, 50% speech understanding in the ear that might be implanted, or 60% or less, not or, and 60% or less in the ear that would not be implanted. And these are just basic criteria for an adult. Candidacy has expanded over the last 10 years dramatically, so that if we can prove that an individual has a moderate to severe loss, and if you look at the graph before, it was pretty flat at the bottom, and here there's more of the hearing in the lower tones, and that speech clarity, because that's the other critical part, is also very poor, then we can consider this person for a cochlear implant. And the expansion has gone beyond that to where someone could actually have normal hearing for a portion of the audiogram, still on the low to mid frequency range, but then they drop out to the very bottom on the high frequency range. And this would be a person also that could be a candidate for a cochlear implant. And here's why. Clarity is primarily driven by the range of sound between 2,000 and 8,000 hertz. So it's the right-hand side of this graph. And where you see that light kind of grayed out area, this would be a person that can't hear in that area. If they can't hear in that area, they can't hear the very soft consonants in speech that are critical to being able to understand words and sentences. So this would be a person that is using hearing aids. They can hear sound, but it is not clear. And we've expanded indications beyond hearing loss in both ears to having hearing loss even in just one ear. In January of 2022, the FDA approved the implantation of one ear for single-sided deafness. And that would mean that the person considered for this procedure can hear in their opposite ear. It could be normal, perfectly normal, no hearing aid, or there could be a mild amount of hearing loss in the non-implant side. And it's considered single-sided deafness. The reason that that became or has become a procedure that we can do is it's been proven. Our heads, our ears are designed with two ears. The two ears work together in conjunction to provide us the sound that we need in the world that we live in. And when one ear is lost, there's a significant loss in speech understanding, especially in noise. There's a significant reduction in quality of life, and there's a significant increase in listening effort. The provision of the implant for the deafened ear restores much of that to the person. And then what they have is a normal hearing ear on one side and the implant on the other side. The implant helps to augment all of the hearing that's happening on the normal hearing ear side. So how do you go from having hearing aids and maybe having one of the audiograms that we just looked at, maybe even the one right in front of us, which is probably more typical where there is better low frequency hearing, to getting to someone that can refer for a cochlear implant evaluation? There's a rule that was developed a couple years ago called the 60-60 rule. And this is something that's being taught to audiologists now. And it's been written in several articles. You might have even seen it. This 60-60 rule was written and researched by Dr. Teresa and her team at Cochlear. She is Director of Audiology Access and Standards of Care at Cochlear. This rule states that a person should be referred for an evaluation if their speech understanding while being tested, if their speech understanding score is less than 60% on a specific type of word test, and if they have 60 dB or greater hearing loss with a specific measurement. So I'm going to say that again because that was a little confusing. The audiologist will do not just the audiogram, but will test for speech understanding without a hearing aid, just under headphones. And if the score with word understanding is 60% or less, and the audiogram looks very similar to the one that we are looking at right now, then the audiologist can say, it looks like you could benefit from a cochlear implant. But the person that's being tested, seeing those results, could ask, do you think I could be referred for a cochlear implant? This is a fairly severe hearing loss. And here's why it's a fairly severe hearing loss. The speech understanding piece is critical to success with any hearing device. If you have a hearing device, you have a hearing aid, and you score 90% or greater on our speech testing, then that means that when you're wearing your hearing aid, you're going about your day, you're not really thinking about your hearing loss. You feel that you're connected to what you need to be connected to. You're not changing volume, you're not changing program. If you do it sometimes, it's no big deal, but you're pretty comfortable. If you're at 80%, then you start to think about it more. There are things that you're missing. And so you think about your strategies. Where am I going to sit in a restaurant? Who am I going to sit next to? You might change volume more often and change program more often. You get down to 70 though, and your hearing ability is right on the edge of fair to poor. Some people at 70% can still get by through their day. They'll use a lot of strategies. They'll change programs a lot more often, change volume a lot more often. They'll realize that there are things they're just not going to be able to hear very well. They might start to implement using a lot of accessories and tools to help them hear in different places. And for some people that works just fine. That's, they know this is what it is, and they think, okay, that I can get by with this. At 60, you can't get by anymore, 60% or less. And that's where that 60-60 rule comes from. 60% or less means you're thinking about your hearing loss all day. You're thinking about, what do I need to take with me so I can hear in this situation? You're thinking about not going to places that you want to go to, turning down invitations, turning down lunches, because at 60% or less, you're missing quite a lot of what's happening around you, and especially if there's background noise. So when we think of the 60-60 rule, if you're experiencing those things, you could probably then go ask your audiologist, what is my score? What is my speech understanding score? Maybe you didn't have a distinct conversation about that. If you're having those symptoms where you're struggling as much as what I just described for 60% or less, then you're probably someone that should ask to be referred for a cochlear implant. What I look for in someone after they get a cochlear implant is not only are they hearing at the top of that graph again, but that they're hearing speech at 70% or better. And so now you might wonder, well, what was Junie hearing at? Remember Junie at the beginning of our talk here? She loves her implants. She says they're incredible. They're like color, expanding color in her world. Well, her scores are 90% or better. So that kind of makes sense. Daisy says, I regret that implant. I should have never gotten that. But her scores are 80% or better. So what else is maybe going on with Daisy? Let's investigate that some. So let's talk about what an implant is and what you can expect it to do. An implant is technology. It is what it sounds like. There is a physical object that's implanted in behind your ear that acts as the stimulator. It's a neurostimulator. And pictured here on the screen in the middle on the left-hand box is the neurostimulator. That's an example of an internal cochlear stimulator. You notice that there's a portion of it toward the top that is the antenna. It's responsible for receiving the information from the piece that is right next to it. On the left, that is the sound processor. There's a second sound processor on here as well. The processor on the left is a Nucleus 7, and it's an over-the-ear device. You wear it on your ear. There's a magnet. The magnet holds it in place, just positioned over the antenna of the internal stimulator. But the one to the right, that's kind of a button, the black one that's called the Canso 2, That's an off-the-ear processor. The one on the left, the Nucleus 7 and the Canso 2, do exactly the same thing. They're just a different package for it. And then on our right is a picture of someone actually wearing a cochlear implant device. The normal hearing ear is responsible for picking up sound from the outside, funneling it through the ear canal toward the eardrum, which is in the middle of the screen here. Connected to the eardrum are 3 small middle ear bones. We're working kind of from left to right in this image. It's the image of the external part of the ear as well as the very inner ear processing system. Beyond the 3 middle ear bones is a small coiled shape. That coiled shape is called the cochlea. Inside of the cochlea is a membrane that houses 15 to 16,000 sensory cells that are responsible for taking all of this sound information that flows through the ear and converting it into electrical pulses that's picked up by the hearing nerve. A cochlear implant takes over the job of that small snail-shaped organ in the inner part of the ear simply by capturing the sound from the outer piece called the microphone with a battery and a coding system, sending that information through the transmitter and magnet to the internal component that has been implanted by the ENT surgeon, the otolaryngologist. And then there's an electrode array that is inserted from the internal stimulator into that coil shape in the inner ear. And to the right of this image is the coil shape blown up so that you can see how the electrodes sit in the inner part of the ear. So the implant takes over the job of that coil. It converts the sound that's captured externally, codes that sound, sends it across to the internal implant, and then sends designated electrical pulses to each electrode in real time, just as sound happens. Now, sound is a physical change in our environment. It's just a waveform. Sound enters the ear as waves and pressure changes. Low frequency and bass sounds are introduced as slower pressure changes. High frequencies or treble sounds are faster pressure changes. Loudness is dependent on how strong those pressure changes are. They're instantaneous and highly complex. In any given moment, there are a multitude of frequencies and loudnesses that are presented to the ear. The ear has to convert those pressure changes. The cochlea converts the pressure changes into electrical pulses. The part where a normal hearing ear or an ear with a hearing aid and the cochlear implant are similar are the next 2 parts. The electrical pulses need to be transmitted to the hearing nerve. Well, an ear that has a cochlear implant does that. The cochlea does that before it has an implant. And then the brain has to receive all of that information. That's why the hearing nerve is critical. It has to be healthy. And that series of pulses, after they're being delivered to the brain, is where you hear. You actually hear in the primary auditory cortex. So we don't hear with our ears. We don't hear with a hearing aid. The hearing aid and the cochlear implant allow our ears to deliver the information necessary so that our brain can hear. It's just simply the transmission of sound to this part of our whole cognitive process. What we know is if that doesn't happen, that the frontal lobe will start to take on a lot of changes. That's where there's stress put into the frontal lobe, memory gets stressed, cognitive function gets stressed, executive function gets stressed. That's why if you don't treat your hearing loss and treat it effectively, that there are changes in brain function over time. And it doesn't happen quickly. It happens slowly, but it is significant. So we have to get that cochlear implant system to process the sound as close to what a normal cochlea would do as possible. And we can't replicate exactly. We know there are limitations to implants. I said there are 15 to 16,000 sensory cells in a cochlea. And we put an implant into someone's ear that has 12 electrodes. That doesn't make a lot of sense, does it? Part of the job of the implant on the outside and the processor is to maintain as true a representation of the world of sound as possible, to create a defined, detailed code as much as possible, and then deliver it to the implant. And then the implant itself has to be a very smart implant. It has to be able to generate and deliver in exactly precisely timed manner all of the electrical pulses to each electrode as is prescribed by that entire coding strategy. And it starts with us replicating sound. And there are two elements to sound that are critical for our ears to hear or to convert for hearing in the brain. And those are called the envelope and then the fine structure. And I mention that because when you read the marketing material around cochlear implants, there's a lot of conversation about preserving envelope and preserving fine structure. 30 years ago, when I started with implants, a lot of what implants could do was simply capture a pattern of sound and deliver that to the hearing nerve. And that pattern of sound was kind of the gross overall change in sound pressure waves represented by that thin white line above all of the more finely drawn waves in blue. That thin white line is considered the envelope. And you can hear just that information. You can get just that information into the hearing brain, into the brain, and what you hear is kind of the pattern of speech. So that in quiet and with training, you can hear words and sentences because your brain will recode itself to the information it gets. But then music is hard to hear and understand and appreciate, and hearing and background noise is very difficult. And that's what that blue line is critical for. That's called the fine structure of the sound. And I kind of liken this to a piece of candy. I know it's kind of simple, but as an analogy, it might work. So this is a piece of chocolate. It has a very nice chocolate outer covering, and then it has a cream filling. If you can only get the envelope information with hearing, then you bite into this chocolate. The analogy is that you taste the chocolate, but you can't really taste the inside, the cream. It's kind of bland. But when you put that fine structure in place, you bite into the chocolate, you taste the chocolate, and you taste the fruit and the nougat and the almond and the truffle. You taste all the different flavors. And that kind of takes us kind of to what Junie had explained as, I had 16 Crayola crowns and now I have 64. It's like there's an explosion of sense and sensory information. And with practice and with listening and training, then sound does become much more enjoyable. Not normal, but enjoyable, useful, and something that can be shared with everyone, like music. So what's the best implant then? Do they all turn bland chocolate into something that's this amazing, flavorful experience? And yeah, the short answer is they do. There are 3 companies in the US, Med-El, Cochlear, and Advanced Bionics, that have been approved by the FDA. And I put on this screen some of the information about the companies, because another question I get is, how long have those companies been working with cochlear implants? Where are they located? Why is one better than the other? And how they've all been approved in the US for 30 plus years. They have all designed implant systems that have been forward thinking, meaning that some of my patients started out with just a bland piece of chocolate with their original implant 20 years ago, but they've been able to access this new external technology over time, and that has expanded the experience. It's got just a lot more color, a lot more flavor to it, and they enjoy that. So is one better than the other? Well, this is a nice chart to just divvy out some of the marketing information about the different companies. What we have are features on the left-hand side, and then the three companies: Cochlear, which is one of the more common ones in the US, Med-El, which is very common in Europe, and Advanced Bionics, a very strong competitor. They have different types of processors. Remember, the processor is on the outside of the ear. It's the small computer with the microphone and the battery that's responsible for capturing the sound and coding it. They have, under features, they have all an over-the-ear processor. And then for Cochlear and Med-El, they have an off-the-ear or a processor that will sit just on the magnet that's been implanted by the surgeon. They're all rechargeable. They all have also a disposable battery option. They all have dynamic microphones. That's a very important element to this whole system, because our ears naturally are designed to keep some information and get rid of other information, to help us funnel and track and localize information in a very specific way. The dynamic microphone mimics that action. It's not exact, but it does bring back some of those skills that you would have had if you had a normal functioning ear. They all have an automatic sound sensor, and that's with the processor as well. We don't need all of the sound from our environment to come through the implant system. We need a very defined type of sound, a specific sound. We want some of the noise to be thrown out, but not all of it. We want some soft sound to come through, but maybe not all of it. We want loud sound to be heard and noted, and for us to be able to track it. We don't want it to be too loud so that's uncomfortable. And that's what the automatic sound sensor does. They're all compatible on some level with a cell phone or smartphone. Med-El at this point, however, doesn't need an adapter, but once you have the adapter, it will connect your processor to the phone. Cochlear and Advanced Bionics don't need that. Getting a little deeper into the technology, Cochlear has 22 electrodes that are inserted. Med-El has 12. Advanced Bionics has 16. I'm always asked, well, 22 must be best. But I've had Med-El patients with only 16 active electrodes score 90% or better on our speech understanding tests that we give. So electrodes in and of themselves do not define the implant system. They all have a coding strategy that captures that envelope and that fine structure with the sound. The idea is to preserve the elements of sound that are most important for speech understanding. They all have that. They all have full day battery use. That didn't used to be the case, but now it is. They all have accessories to enhance listening in challenging situations. So they're very comparable, just, on paper. So which one is the best one? Because everyone asks me. Well, back to that question of what is an implant? It's technology to hear. It's technology to get information to the brain so that we can hear. The best implant is the one that you and your audiologist pick. It's the implant that has the technology that you feel comfortable with. It's the implant that has the physical pieces that you feel you can manage. All of these implant companies are playing off of, building off of current technology, advancements in technology like Bluetooth, rechargeability, noise canceling technology, smartphone compatibility, advanced audio technology. They have all developed their own brand specific accessories. They all have the ability to give you the best hearing that they can through their implant system. I honestly don't believe that one is necessarily better than the other. I believe that the audiologist and the patient determine how to make the best out of the technology and the hearing. It has to be specific to the person and it has to meet your needs. I have some patients, just to give you an example, who will tell me, you know, I don't have a computer, I don't use email, I'm not getting a smartphone, it's just not technology for me. Or as soon as we mention technology, there's kind of something that turns off. And here's what I would say is, you got a cochlear implant. If you get a cochlear implant, you're getting technology, you're getting something that's high-end advanced technology. And if you can manage that on a day-to-day basis, you need to expand on it and get the technology that works with your implant system. And this is a really good TED Talk about normalizing technology. And millennials, it's kind of funny, two of my children are millennials, just from the age range. They love to help me with my technology. Mom, let me show you this. Mom, oh, you're doing that wrong. I think that's great. You need to have those people in your lives that help you with that technology. But more importantly, you need to get it. There is no reason now with an implant system to not use the technology that's been made available through, I guess, you know, the younger generation and what they want. We don't have to use the technology the way they do, but all three companies that I've mentioned, they have an app that you can put on a smartphone, and it has to be a smartphone. It can't be a flip phone. I know that can be a problem in terms of T-coil, but if you're getting an implant, you should be converting away from flip phones, older phones, or simple phones, and getting, I guess, what you might call a smartphone, because this is going to change how you manage your hearing with an implant. So just want you to know that if we think back to Junie, who loves her implant, our original stories, and Daisy, who does not like her implant, they have two different models. They don't have the same model implant, but that is not the reason that they're not having equal success with their implant systems. When you think about when you should be getting an implant, and this ties a little bit to Junie and to Daisy, they both experienced the same types of symptoms. They were frustrated. They were exhausted by the end of the day listening with their hearing aid technology. They were backing away and isolating from things or missing things. So when your hearing is at that point, then that's when you think of getting a cochlear implant. That's when you have the discussion with your audiologist. That's what they both did. That was completely appropriate. And in testing, they both qualified pretty much the same way. They both had speech understanding that was well below 60% on all of the testing that we had done. So the timing was right for both of them. And where do you start? Well, they both started in the right place. They started with their audiologist, and then they got a referral to an ENT, or maybe they started with the ENT and got a referral to the audiologist. Either way works. You can talk to now your primary care physician. You can talk to an audiologist if you have one. You can go to the websites for the cochlear implant companies. They all have something called Clinic Finder, and it's at the very top of the landing page for all three of them. You put in your zip code, and you'll get a list of clinics, not necessarily implant centers, but clinics that have been trained on cochlear implants. And that means that you could call and make an appointment for yourself at one of these clinics, have your case reviewed, have some testing, and start that process toward being considered for a cochlear implant. So you can do this for yourself. You don't have to wait for someone to do this for you. You can talk to your friends, the community within the HLAA. You guys are all super tech savvy. I've learned so much from working with some of you that come into my clinic now. Talk to a cochlear implant user. All of my patients come to me quite often and say, "You're just not going to believe what happened to me. I was standing in line at the grocery store and someone came up and asked me about the implant I'm wearing, and that they were thinking about getting an implant." You can connect with a specialist within one of the implant companies. Let's go back. I'm going to show you how to do that in just a minute, to connect with a specialist in one of the implant companies. Let's talk about how you can be successful first, and then we'll come back to that. Hearing is a very unique experience for every person that has normal hearing, hearing loss, and implant. It's your own personal experience. It's a neurologic experience. It is dependent on your life. What is your lifestyle? What do you enjoy doing? Are you someone that leans a lot toward music and spends a lot of time in music? Or are you a person that spends a lot of time reading books? Is it that you might have other health concerns, and those health concerns take a lot of your time and it's hard to manage and you have a lot of appointments? So each person is unique, and your audiologist and in the process of maybe being considered for an implant, they're going to ask you a lot of questions about your life and your lifestyle, because we want to tailor how we help you to your needs. It's different for everyone. The asterisk points that I put here, you might not think about as being critical to a success with a cochlear implant, but having support with family, friends, significant others, I think that's critical. They need to know what's going on with you. This is a huge change in your life. You need to get them involved in this process. You need to think about, how long has it been that you've had a hearing loss, and how long did you go before you actually got hearing aids, and what were your expectations with hearing aids? That carries over to the implant. What do you do before surgery to learn about the technology? How are you setting your expectations, and what are you doing after surgery to keep learning about the technology? It's always changing, and also using it. And then, how does this implant make you feel? A lot of my patients will say, I have to get used to having this and people seeing it. And that's important. It's important to talk about that and to think about, how does that affect your day to day? And sometimes it comes down to, how am I going to put my hat on when I play golf? How do I wear a scarf and have it not fall off in the winter? And, you got to have answers for those things. And I talk to my patients about the physical parts of wearing the implant, taking care of the implant, and I take those seriously with them. If there are other health issues and concerns, then we have to think about how this fits into their life with everything else that they're dealing with. If there are memory challenges, that's critical, because then we do need family and support externally to help with remembering how to do things. So you're not going to do this alone. You're going to do this within the community that you develop, that you create. And think again back to, how long does it take to get an implant from the time that you're referred? If you're at that point where you're thinking about it, you're going to go talk to someone, that's when you need to reach out to the community. You need to join community support opportunities like HLAA. There's a huge support community within each implant company. There is the professional support audiologist, ENT, go to those visits with your questions, be specific, let them know why those questions are important to you. No question is unimportant. And then pay attention to social media. Okay, again, get a smartphone, get a phone that you can actually like kind of delve into, well, what is in the implant community online? There are blogs. What does that mean? Basically, those are articles. So you go and read about other people's experiences. That's significant because there are people within the implant community that are sharing their stories, and it might surprise you that their story is very similar to your story. And then you can figure out that you're not alone and that you have someone that you can connect to. I mentioned earlier, the implant companies now have all three of them. Cochlear has recipient solutions managers, Advanced Bionics, the AB Success team, which launched, I believe, June 7th, like yesterday, and Med-El consumer engagement managers. So these are all trained professionals within the company that are only there to support you getting a cochlear implant, you learning about your implant, you having questions answered about your implant, you finding other people to connect to that have an implant. When you change the equipment of your implant, you can go back to this group, and it's another person that's been specially trained that can show you how to use your implant and direct you to services. This is a critical piece. You don't want to ignore this piece that's being offered to you by your implant company. When I mentioned the blogs and the articles, I want to give a call out to a longtime friend of mine, Tina Childress. She is an audiologist in Illinois, and some of you might know her. I think she's presented for HLAA in the past, probably on a lot of different levels. But she has written articles based on her experience as an audiologist who has a cochlear implant, and also using technology like caption and FM systems and loop and telecoil systems. She's one resource. There are many, many other resources. And there's technology that at first might seem like it's not something that you can kind of get your head around. But I have a lot of patients who have converted from using no cell phone to using an iPhone. And then I introduce them to caption, and they come back to me and they're like, caption is like the greatest thing in the world. Even though they can hear on their phone, it's the captioning that enhances the communication. Here's the other piece to that, though. Don't do this just for yourself. Do this for your family and your friends, because they want to be able to communicate with you as much as you want to be able to communicate with them. They want to tell you things. They want to share when something maybe dramatic has happened. And if your hearing loss prevents that, and your ability to use technology prevents that, then we have to find a way so that we can restore it. And, there are lots of resources there to help you do that. Your audiologist, these outside resources like the blogs and social media, articles, online resources. And the thing is that if you can't find something and you need it, then just ask. And if nothing else, I'm happy to help you find something if you need it. Okay. Who would have a car and not know the model of their car? This is a Tina Childress comment. Do you know the make of your car? Do you know the year of your car? Do you know the next time that it's due for an oil change? Like, why would you not know your technology for your hearing implant or your hearing aid? Know the brand of your hearing aid and your implant. Please know that. Know when you got it. Know when the warranty ends. Know the name of your audiologist and your otolaryngologist and their contact information. But more importantly, write this down and put it in a shared space for family and friends. I can't tell you how many calls I get from a hospital, and a friend or a family member has called to say, we can't figure out how to make this work. That's an extreme case, but there are many other times that you might need help with just understanding this, or a reminder. And You know, why shouldn't you have this? You need to know how to manage your hearing devices. This gives you control. This gives you agency. This gives you the ability to have conversations that are meaningful with the people that you're working with. So write this stuff down, know it, and then show it to someone else. Keep a sense of humor. Hearing loss is hard, it's challenging, it puts up barriers, and sometimes it's really, really funny. If you've heard something and then someone gave you that look like, oh, you didn't hear me, what do you think I said? Or you said something that was really off key, you just got to laugh about it, because you got to own it. Say, you know, I have a hearing loss. I have a hearing aid. It helps me, but it doesn't help me with everything. I have a cochlear implant. I can hear you really well here, but I'm not going to hear you really well here. I thought you said this, and that's really funny because I know you would never say that to me. So you just got to laugh. So say, well, that's just kind of, you know, the way it is. We at Ascension love our patients. We love helping them. I love the people that I work with. I have my fax here and my phone number. I'm located at Carmel St. Vincent Hospital. It's in Carmel. And that fax number is a really helpful number, because if you ask your ENT, your physician, to refer you for an evaluation, all you have to do is give them that fax number. And Carmel, Ascension, St. Vincent Audiology, and they can make it happen for you. So thank you for listening to me. If there are questions, I'm happy to answer questions. Yeah, so what's next? Teresa?
So I'm Paula, and I'd like to thank you, Cathryn Luckoski. It was very informative, wealth of information, and a lot to consider when deciding upon a cochlear implant. And it takes a team to help make that decision.
So true. Thank you, Paula. Very kind.
Kathy, would you stop presenting, please?
I would try. Oh, I see it. Thank you. Thank you, Ella. I'm almost there. I did it.
Well, we're moving into the question and answer period. If you have a question, you can raise your hand and we'll call on you. Otherwise, you can enter a question or comment in the text box, the chat box, and we'll cover it there. And we already have some questions. So let's see if we have anybody that has their hand raised. I don't see any hands raised. We'll come back to that, but we can go to the chat box. And we'll just go down the line here. Teresa said that she is a candidate for a cochlear implant. At least she was at one point for her left ear. However, due to her Meniere's disease, she was told the second time she was tested that she couldn't be a candidate. And, it's very tricky when you have Meniere's disease, since hearing fluctuates. Have you had many candidates with Meniere's disease, and do you have any comment about this?
Yes. Yeah, I think Meniere's disease is probably one of the more common, and there are many different reasons that a person can experience hearing loss. Meniere's describes that set of symptoms of progressive and fluctuating hearing loss, balance issues, and then periodically or consistently having just auditory sounds that can sometimes just overtake your life. There are a lot of different reasons for Meniere's, however, and I think that the idea of fluctuating hearing loss is an important part to determining whether an implant might be a better option. So I have some patients who similar sets of symptoms, Sometimes they hear better, sometimes they hear worse. And we take that into account when we're evaluating for a cochlear implant. Oftentimes, the veneers in the ear that gets implanted gets better. That doesn't necessarily, it isn't a guarantee, certainly, but just there seems to be kind of an overall impression, not just from me, but from the ENTs, that those symptoms can improve. What I would say, if you have one test that shows that you're a candidate, it's probably looking more specifically at the speech understanding. So on that bad hearing day, the speech understanding with the hearing aid was below the threshold to qualify. And then on the next test, the speech understanding was above the threshold to qualify. Those are data points. So I always report to insurance companies, to the ENTs, and I rest some of my recommendations on the data points. That fluctuation is an important piece to making a recommendation for an implant. So without looking at the exact data and and more information about the history and having a full evaluation, I would think that alone would not completely disqualify you. It might be important to just revisit it, have another evaluation, and then look at it over time, as well as all of the other hearing issues that you might have experienced. Am I feeding back?
Teresa, does that answer your question?
I'm hearing echo.
Yes, thank you.
I am
Thank you.
too.
Yes. I heard a feedback too, but I don't know where that was coming from. Maybe somebody has their phone on as well as the computer. If you have two different devices on with the meeting, that can cause a feedback. Anyway,
Okay.
go ahead. Thank you.
Okay. Well, thank you for those questions and the answer. Carolyn has a question. She says that there's been a clinical trial at the Mayo Clinic involving the Acclaim fully implanted cochlear implant, ACCLAIM. And she gives a link to that for more information. And she's wondering if you have an opinion on that.
It actually is an FDA trial that's going on regarding a fully implantable cochlear implant, and I'm on the cusp of getting a CI. I don't, I thought, well, maybe I should wait.
It's a really good question. I'm often asked, should I wait for this next technology? Should I wait until it's smaller or better? And basically, no. If you are having the difficulties that I described earlier, you should just go ahead. It should be now, because new technology most likely will be compatible with whatever implant you get now. In terms of fully implantable devices, those have been investigated almost the entire time that I've been an audiologist. I think that there's going to be a point when it is approved and it's used clinically, and that's going to be a fantastic moment in hearing science. But I guess I don't know. I can't tell you if you should wait or not for that, but I feel that if you're thinking of getting an implant, that you should investigate the current models and what's currently FDA approved, because it still could be years before the model that you found at Mayo is actually all the way through that FDA process.
Thank you. Carolyn had another question. She says that she heard the Canso 2 does not have a telecoil. So if not, why not? Do you know about that?
Yeah, it's really disappointing. Yeah. The Canso didn't either. So the only way you could access a telecoil technology is with an adapter, the mini microphone. You would have to connect the mini microphone because it has a telecoil built into it. The reasoning is the telecoil circuit would have added too much weight and space to the design of the processor. And we have to be able to hold it in place over the magnet site without it falling off and without putting too much pressure on the implant site. So the balance of weight and aesthetics took precedence over adding this other circuit to the device.
Thank
But the
you.
other CIs do have telecoil, correct?
I think Medel has a telecoil in there. Oh, you mean the ones over the ear?
Well, I've just heard that's the only one that didn't have a telecoil, and I thought the other brands had a telecoil. If they have a cochlear implant, I thought they automatically came with a telecoil.
So all of the over-the-ear models do. That's the,
Okay.
the processor that you'd wear, kind of like a behind-the-ear hearing aid. Medel has an off-the-ear model called the Rondo 2, and I think that does have a telecoil. So these are independently designed by the companies, and the circuits, the way they manage battery, that all has to be managed by the developers, the engineers, and for the Canso and Canso 2, Cochlear telecoil in.
Thank you.
And Dawn asked, how is fiber optic implant technology coming along?
So I need more information on that. I don't know about fiber optic implant technology.
Dawn, do you want to come on and elaborate?
Yes, I understand that instead of inserting a cable with contacts on it into the cochlear, they are working on an idea of putting a fiber optic cable in there, which would shine light onto the cochlear. And then there's a chemical, I believe the one they're using is luciferin, similar to what fireflies do, that will convert the light to electricity. Now, the whole point is being able to have perhaps several hundred fiber optic contacts as opposed to the normal 10, 12, or 22. The normal contacts will have a leakage between one contact and to the other. And the electricity will slide from here to, it will leak from here to here. For example, I had an audiologist help me test mine one time by putting a single note into my ear and raising the volume. And as the volume raised, the frequency of the note stayed the same until eventually there was leakage from one contact to the other. And then the tone of the note changed. It went from E to E. So that was indicating leakage. Hopefully the fiber optic thing would not have such leakage. So I've been told that they're kind of working on that and wondered what the latest was.
That's really interesting. So I haven't read anything on fiber optic technology. What you described with that crossover effect between two electrodes is absolutely an effect. It's true. Some of the measurements that we do when we're setting the implant are to minimize or eliminate that to the best of our ability with the anatomy and structures of the cochlea. That's also one reason, as you noted, that we either have 22, 12 or 16 electrodes, and the distance between electrodes is very specific based on the implant company so that we get the least amount of crossover, as you called it. It sounds really interesting. I'm going to go look that up. I don't know.
We'll
Well,
have to
thank you.
follow how that technology evolves. Thank you. Did you want to say something more, Dawn? No? Okay. Okay, well, the next question is one I have. When evaluating for a cochlear implant, are speech understanding tests done with or without existing hearing devices, or both?
That is a really good question, Paula. So they are done with both, but they're done for different reasons, with and without hearing aid. So without the hearing aid, that score is more related to tracking over time how speech understanding might be affected by changes in hearing levels. But we don't know how much a hearing aid might help you until we fit a hearing aid properly and then test you with it. And that's primarily the score that we're looking for and the outcomes that we're looking for to determine if you're a candidate for an implant. The ear is, when an ear has hearing loss over time, the structures become damaged in ways that we cannot physically see. The speech understanding score gives us an idea, a picture of how well the ear, with its structures all intact, can process and convert that sound into those electrical pulses. And at some point, if there is significant damage to the structures, whether they're the sensory cells or the supporting cells of those sensory cells, if there's significant damage, we cannot recover that with a hearing aid. And that's what that test proves, is our ability to recover functionally hearing just by, measuring speech clarity and speech understanding. So it is aided with the devices that you're wearing.
Thank you. Ernesto's wife says, "Why does my husband say that he hears as if she was speaking in a box?"
That's a good question. Is that like all the time, some of the time? There are probably a lot of reasons. I think I would need to know a lot more to try to tease that one out. And then I don't know, do you have an implant or do you have a hearing aid, Ernesto?
I hear just through my cochlear, and what I hear is like somebody is talking to me with a head covered like this, and it might be this is all the system can deliver, or maybe I don't know. I've got used to it anyhow. So my wife is just curious like that.
And I'm smiling a little because I do hear that comment. I hear it more toward the beginning of getting used to an implant. And I don't know if you remember, and I didn't really close the loop on Junie and Daisy, my two stories. The reason that Junie did so well is because of how much she practiced, how distinctly she practiced with her implant, 30 to 60 minutes a day. It wasn't because of the implant that she had, but for her and, my other story, Daisy, neither of them liked the sound the first day that they heard with the implant. And in fact, one of them commented and said that the sound was both too loud and too soft at the same time, as well as tinny and scratchy and echoey. There was just a long list of all of these things that were not what it was supposed to be. Those are symptoms of the ear that you have. You have hearing loss, and there's damage that's happened because of the hearing loss. And what we have to do is train the ear to hear differently. But actually, it's not really training the ear, it's training the whole hearing system in the brain to hear differently. and I don't remember what you said. How long have you had the implant?
About 3 years.
3 years. So, and I have had some patients who, long-term have that kind of lingering effect. Again, I probably would need to see more information. When I hear that from my patients, though, I will go and then look specifically to see if there is an area in the inner part of the ear that maybe is not strong enough for the implant, and look to the possibility of limiting the contacts in that area. So turning off electrodes, reallocating electrodes. And I'm sure that you're going to a fine center and they have already maybe tried some of that, but I definitely would suggest that you go back to the audiologist that you've worked with and try to describe that in different ways for them, when you notice it, when it's worse, how it impacts your ability to hear on a day-to-day basis. What are you missing because of that symptom? Is it a lower frequency box? Is it a higher frequency box? Because those types of descriptions help us to pinpoint the area that maybe needs to be looked at more specifically.
Okay, could it just be the limitation of the technology?
Ask me that one more time, I'm sorry.
Could this be just the limitation of the technology? Like you put on glasses, it's not exactly the same as not having glasses.
So it could be a limitation. I mentioned we're not restoring hearing to 100%. We're using technology to capture back as much of that hearing experience as we can. But, I also said that the 3 implants by design, as long as they are fully functional, have equal opportunity to provide a great outcome. So I wouldn't say that it was a limitation of your technology specifically. It could be something else, like the hearing loss, the length of hearing loss, the ear itself, the program within the technology.
Yes, there is a long story, and I don't think this is the time to go over that. But I'm going to check with my audiologist next time I see her. Thank you.
Thank you.
Okay, we're running a little bit short on time. I just want to let Shirley ask her questions. She asked, does hair grow over the area with the magnet, or does it have to be hair-free? And then her second question is, when getting used to the implant and adjusting to hearing and a tinny sound, will it be more difficult in general to hear during that time?
2 really good questions. So the first one, it varies. It depends on the person. So I have some patients who just have really thick hair, and the hair is always thick. It grows over where the magnet is. And so we have to adjust magnet strength to kind of accommodate the amount of hair that tends to grow underneath the magnet. And then there are some others, that if you tend to have, thinner hair, not as thick, then I don't think that the implant itself causes hearing loss, but once everything heals, your scalp is your scalp, and the hair is going to grow back after the surgery. And it'll grow back to, the hair that you have. The tinniness, and it's not always tinny, but that tends to be a common response or reaction to the implant. Is it harder to hear? I would say it is, but it's not because it's tinny. I think that they are symptoms that kind of go hand in hand. At first, the ear is just kind of like waking up and figuring out what the heck happened. All of this new information is coming through, and the nerve and the supporting structures are, they're trying to figure out what to do with it. And you think about any other part of your body, if you just didn't use it or use it appropriately for a really long time, you wouldn't be able to move it and get it to do what you want it to do. You're going to have to practice with it. You're going to have to get strength back in it. And it's the same way with the ear. And so those weird symptoms in the first couple of weeks with an implant are secondary to the ear coming back online again. And as those symptoms abate, the clarity improves. So they kind of go hand in hand. I'm not sure one causes the other, because I can still have patients tell me that the sound tends toward that higher pitch, even though their speech clarity is very, very good. But over time, we expect all of that to level out and improve for sure.
Well, that concludes our presentation today. Thank you so much. It's been very informative and lively. And I'll turn this back over to Teresa.
Okay, thank you so much, everyone, for coming today and joining us. And thank you, Dr. Luckoski, for this wonderful presentation. I think we've learned a lot. I know I have. I will be sending, on behalf of our chapter, we'll be sending a certificate of our appreciation to you. And then we have a little token of our appreciation coming your way. So thank you so much. We got a lot of people clapping. Thank you so much for coming and speaking to us today. I think we've learned a lot. So thank you. And everyone have a great Saturday. Goodbye. Don't forget, if you want a copy of this recording, don't forget to leave your email in the chat box. Thank you.